All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. This is our chit chat. And Doug was saying that he wanted to see Luffy, so I'm going to bring Luffy. So here is Luffy. Luffy, stop. Okay, so that was Luffy. So Doug, I hope you saw Luffy who ran away. And now Luffy is going to go out. All right, so hey Denise, how are you? Yes, Luffy is a very cute cat, and he knows that, and because of that, he's a snob as well. Okay, cool. So let's start with the questions. So here is the first question. Joe says, can you interview Dr. Shankara Shetty, general medical practitioner in South Africa for early treatment for COVID-19? Sure, we can. I'm gonna take that note here. Okay, perfect. So we'll reach out to him. Doug says, in non-comorbid adolescent, does Pfizer reduce cases, hospitalization, and death? EUA efficacy is based on trial size, 1983 with 16 cases. Is that large enough? It's not large enough, but I think considering children, this may be at least a good trend setter to say, let's see it. Generally, it's not a small study, so it is a decent size, it is fine. But for a vaccine which is going to be given to millions of people, I think a larger number would be interesting. So, all right, so let's see. Dishri says, sir, please speak about pancreatitis and hepatitis in COVID-19. Okay, so is there some specific problem that we should talk about? Meaning it happens, many tissue damages occur. What is the question? This is a very broad question. Nancy Park says, forgot the question about black fungus in India. So Nancy, I'm going to talk about it. It is I think the reason is steroids, and then diabetics. On top of that, they're receiving steroids as well, and that is causing their immune system to go down, and these fungi become opportunistic and they cause infections. So let's see. Question, if a person has had COVID and has antibodies, should a person get one Pfizer shot or two if they still want the vaccine? Thank you. So good question, and I have been discussing this multiple times. So let me share my screen, and then we'll talk about this. So generally, save this. So look, generally what happens is that we have, let's say we have this infection, the actual SARS-CoV-2 that has arrived in our body and has caused an issue. So now for this SARS-CoV-2, our body is going to make antibodies against many parts of the spike protein, the M protein that are present in its envelope, other proteins in the envelope, the N protein, which are inside the virus, but when the virus would break, these things would come out. So the N proteins and RNA and so on. So there are multiple kinds of vaccines that, antibodies that are produced, number one. Number two, the virus particle, when it arrives in our cells, it actually continues to divide, right? It increases in number. And then it comes, those particles, the daughter viruses, they come out, and then they go to the other cell, and then they divide again or replicate again. Then they come out, and this chain continues for days and days. And that causes an increased number of viral load or antigen presence, which causes the immune system to become very, very active and upset and react to the virus. In majority of the cases, our immune system is able to handle it. In some cases, it is not, or it handles it overwhelmingly resulting in severe damage or death of the person. Now, with this kind of an immune system response, if we say that, hey, we should give this person a vaccine as well, then you tell me that what is the need for a vaccine if somebody had been already protected by their own body system against the virus. Now, there are some caveats. Number one, imagine that between these 2 points, A and B, let's say this is January of last year and this is January of this year, so 2021 and 2020. If between these 2 points, and this can be any 2 points, it's not necessary that it has to be a year, between these 2 points, if the person, they become different, for example, their immune system becomes less active, or they become diabetic and their immune system is now less active because of diabetes, or they receive chemotherapy, or they receive radiation, or they received organ transplant, or they started corticosteroid therapy, or they started other immune modulators. So now it is possible that their immune system need to be boosted again. So if they say, yeah, sure, give me a vaccine because my immune system is still not the same, or is not the same as before, that had learned to fight with the virus, then it makes sense. The second possibility is that the virus itself has changed here. So it was like this over here, but now the virus is different and it has different structures. So the antibodies that we had developed when we got the infection, these antibodies are not able to control this virus anymore because virus is different. If that is the case, then getting the vaccine with the newer virus version would also be interesting. So I hope that answers this question. My general opinion is that a person who has become successfully, who has defeated the virus, don't need the vaccine. I'll also give you some more data. In Israel, they said anybody who had the infection, 90 days after the infection, they should get the vaccine. So that is one more data point. And another data point is for the long haulers, about 20% of the long haulers say, not all, about 20% of the long haulers say that when they got the vaccine, their long haul symptoms disappeared or improved. So that was that question. So let's see. Dr. Z says, please excuse my inattention if I missed it during the discussion. Were there any severe cases or deaths in the control group for the children's trial? They did not say it. They only said infection. So it was actually not you who missed it. There was no mention of that. So I am still now looking for the data, the debrief data, and I'm going to come back with some more of that information. So good question. Tom Johnson says, Dr. Bean, you think it is fine to give kids a so-called vaccine that have not had long-term side effect studies and have not been licensed only EUA while kids are least affected? This is a crime. So Tom, looks like a rhetorical question to me. My opinion, vaccines have been given to children all along more than the adults. We all used to get vaccines when we were children. However, your point that it is a new vaccine, we do not know the side effects yet. I agree with that it is a new vaccine. What happens with it in long term, we do not know. My own thinking, considering the science behind these vaccines and the way they operate, I feel that there would not be any long-term effects, but that's just me speculating for the future, which can be totally wrong. Just like somebody else speculating to say there will be side effects, they would also be wrong. So we do not know. And then if you use that, sure, you can make a decision. I cannot generalize it to say administer the vaccine or not. I think it is a family's decision to make it together. So Denise says, because Dr. Patterson's lab is finding even those with high amount of antibodies aren't neutralizing of virus when challenged in vitro. So this could be possible. So that is the important thing is this. If somebody has become cured, had the disease and their body took care of it, then good antibody, bad antibody, good T cell, bad T cell, they were able to handle it, done. It is the problem with those who were not able to handle it well, and then we should see what is going on. Marcio Gibson says, hello, Dr. Bean. Did you know some pre-results of mixing matching AstraZeneca and Pfizer efficacy rates studied in England? No, but they are getting ready to publish those results. That would be interesting. I can make a conjecture from the science point of view that I think it would work fine. It is, there may be dose adjustment needed or not even maybe that, and I think it will work fine. And we have done this discussion a few days ago that vaccines are presenting the same antigen. Which vaccine it is, body doesn't care. So CA has a question, should I wait for more data for children vaccination, iron deficiency for daughters, safe blood loss in young women? So this is where I need to have more data to answer this question. So I can say easily to say, yes, wait for more data, but then the risk to the child, and if there is a protection by vaccine, I would be wrong in saying wait, just like I will be wrong to say do it without knowing. So CA, give me a day or two. I have to find the debrief document that they presented to FDA and then look at the various comorbidities that they work with. In general, the deficiency of iron would result in number one, RBC production and issues with the RBC production and oxygen carriage. And then iron deficiency can, in very smaller ways, can result in some other cell productions as well, or DNA productions as well. So as long as she's healthy, meaning she has iron deficiency and then she's receiving the replacements or is in a healthy state, it should be okay, but I do not have any data to back it up. William Goff says, if 12 to 15-year-olds handle COVID well, and the fact that none of the vaccine trials showed the adverse effects like blood clots, idiopathic thrombocytopenic purpura, and myocarditis in their trials, do you feel it's safe for kids? So I'm gonna, for the time being, I'm gonna borrow the data results that are published instead of giving my opinion, because I need to look more in the data. In my what I read from the side effects and the safety is that the safety and side effects were actually very similar to 16 to 25, and 16 to 25 have already been getting vaccinated. But now think about it, Pfizer is known in Israel for 62 cases of myocarditis, and then two children, young age people, 22 years, and I think similar age for the other person who died as well. So there is an effect like that for youngsters as well, and they saw this under the age of 30. So it almost looks like Pfizer's problem with 30 years and under, Johnson and Johnson's problem with women 50 years and under. Moderna, I haven't seen anything yet. Maybe they have not given the data or there is no such data. So they may have to mix and match the vaccines to say this cohort cannot have this vaccine, this cohort cannot have this vaccine, and so on. I doubt that they would do it. I think that they are being lazy about this, but they should do it. Dr. Gaming says, sir, please talk about the role of normal flora in COVID and use of probiotics in COVID treatment. Okay, good topic. Pinky Bean says, good name, very congested with allergies, taking Allegra, Zyrtec, and Singular daily. Any issue getting first shot tomorrow? Will effectiveness be impacted? No. So this is a very important question, and I have answered this before as well. Let's see. What happens is this. When you have allergies, so let's say this is a chart and this is a non-allergic person. So 80% of the people are not allergic to certain things, another 20%. So let's say this is a non-allergic person, and this is their immune system's functioning. I'm just making a rough chart here. It's not a scientific chart, but let's say this is the level of immune system's work or intensity or response. And here is a person who is allergic to something, or to, as you're saying, that you take a lot of medicines. That means generally the immune system is responding more than it should. That means above the normal. Immune system is responding abnormally with more intensity above the normal level. And that more intensity and that more activity is causing problems. So what you're doing is you're taking medicines to bring this extra level to back towards normal. You are not suppressing your immune system to say my immune system should not work from now on. If that is the case, then you cannot handle any infections, you cannot handle any foreign antigens, and you'll be in trouble. So what you're doing is you're bringing the immune system back towards normal. That means it may be that just instead of back to exact normal, it may be a little lesser, or it may still be a little bit active, more active than it should be. So now if you take a vaccine, your drugs have not actually suppressed the immune system. They have kept the immune system to the level where it should be. And so the vaccine would do fine. It would do the work correctly. Okay, so our patron says, Big Pharma sells snake oil so much, they slither instead of walk. Roman is here. Paul Burke, when I look at everything on the surface, government is suppressing and disseminating the early treatment side while always, and I mean always since the start of pandemic. This is very correct, Roman, that government or the organizations should have continued to latch on to any possibility of early aggressive treatment. And then if they tried it and they said, well, it doesn't work, and something else pops up, they use that and try that. I think that should have been a good behavior. I just think that we have all been let down by this, and some of us have died because of this. Melissa Johnson says, should a person take vaccine while on Valtrex? So once again, this is a very specific question. So please talk with your doctor as well. Usually these drugs are trying to just modulate something back towards normal. And so it should be okay. But please talk with your doctor. I cannot give a advice. This previous discussion in which I provided my comment was really to say that when you're taking drugs, it is really bringing the immune system back towards normal, and that would mean immune system would respond normally. Again, that was not a advice. Jerry says, got COVID toe symptoms from Moderna first dose. Foot doctor advised against second. Still not clear 7 weeks later. Please explain mechanics. Serious or not? Very, very interesting. I had not heard of this. So at the end of the day, the vaccine is producing spike proteins. And then those spike proteins are presented to the immune system, and immune system is then responding, creating cytokines, and then there is a process in which the adaptive arm is working. So the ideal result of this is that the body learns to combat with the spike proteins or the actual virus when it arrives. Now, you got COVID toe from the first dose. So the question is, I'm thinking about it, that what could be the mechanism. I have not heard vaccine causing it, and because of that, I'm just thinking aloud. So COVID dose, now I'm thinking with you. So let's say here is a toe, And the reason the toe appears, what happens is that the blood supply to the toes is compromised by COVID because of the COVID damaging the blood vessels. And the question, why does it occur in toes? Because what happens is in the early part, when the blood vessels or arteries come out of heart, they are big. Aorta is a very large blood vessel. And then as they continue to go to various tissues, they keep dividing. And as they divide and divide, they keep becoming smaller and smaller. And so when they reach the foot, that is the farthest point in our body. And so they have become really tiny after so many divisions. And so if there is a tiny bit of an inflammation, it is easy to just block them. And that would cause the local ischemia, and that would cause a Coverto like thing. So eventually, let's say we say it is Coverto, that means there is vasculitis that happened. And vasculitis means the inflammation of the blood vessel wall, and that blood vessel wall inflammation is causing the blood vessel to kind of become the lumen, or the little, the what should be the hole in the pipe, that becomes very small and unable to bring in lots of blood. This is vasculitis. Now we know that COVID can cause vasculitis because the spike proteins would attach with the ACE2. ACE2 imbalance would occur, plus spike protein itself, we talked about the study, would cause the imbalance within the cell. Now here in this case, in theory, spike protein is not free to move around and go around and do whatever it wants. The cytokines can be generated by the cells, immune cells that are working with the cytokine and with the spike protein. And when they release the cytokines, the inflammatory system, that can cause inflammation. So now if I make a wild conjecture, what would happen is that the immune systems picked up the spike proteins, macrophage, dendritic cell. Then they run around and they go to various lymph nodes and show the spike proteins to the B cells and T cells there and say, hey guys, start getting ready. And then T cell and B cell will make their cytokines, they'll become active, they'll make antibodies and so on. Now, in this case, there can be two possibilities, and that is, one, some macrophages are near here in the leg area and they are presenting the spike proteins to the T and B cells there, maybe in the lymph nodes, which are then releasing cytokines, which are causing inflammation. That is one possibility. The second possibility is that as the B cells are starting to make the antibodies, those antibodies are now settling on the surface of the endothelium, causing damage to the endothelium. And this is a known mechanism. It's not a new mechanism. I'm not making up science here. This is vasculitis by the immune system is possible. So what I do not know is that in your case, this Coverto, the problem with the artery, is because of what? Is it the spike protein macrophages in the vicinity causing the production of cytokines and inflammation of blood vessel, or is it the antibodies that are present here and causing this? So both of them are possible. Now, to go to your question, your doctor says that don't take the second dose. I would agree with him for the second dose until there is an understanding of why the COVID dose occurred. Have you recovered from them or not? If you have recovered, good. That would mean that the second dose should be graded for you. And I talked about that a few days ago. I think that is a very important talk, where the immunologists, what they had done was they had taken folks who were allergic to Moderna's vaccine, and they injected them within an hour in divided doses, every 15 minutes, a small dose. So that means you go to your immunologist, allergist, they would look at this condition. They would know, all right, fine, we cannot give the full second dose at one time. They would have you sit down and then they would do a graded dose and they would see the results. So dose can be given. It's just that normal centers may not be able to do it. Cool. So Carol says, what is a Coverto? So Carol, as I just explained, that if the so normally in the toes, blood vessels are inflamed and blood does not reach there correctly because of COVID in children, and then they develop bruises and ischemia and injury there based on how much is the inflammation. Okay, so just looking for the questions. Karen says, thanks, welcome. S. Hamid says, what differentiates Sinopharm vaccine from AstraZeneca one? Sinopharm. When I talked about Sinopharm, I believe Sinopharm was adenovirus based, and AstraZeneca is also adenovirus based. So, from the platform point of view, they are the same. It is the manufacturers who are different, and so that would mean the adjuvants that they use, the formulation that they use are different. That also means the reactions that can occur to the vaccine are different as well. The quantity would also mean the efficacy may be different too. Bonk Bonk says, as a long hauler, I have COVID 13. I have months on. It gets worse with inactivity. If I am active after a few days, it slowly starts to clear. Same mechanism as with vaccine COVID 2. In theory, yes. And it is interesting that you say that with activity. So what happens is that with activity, blood is pumped. And when the blood circulates more, it kind of takes it away. And so then that means when you are less active and there is more less circulation, that means the cells that are sitting there are able to continue to work on producing inflammation and local vasculitis starts occurring. So Bonk Bonk, have you tried steroids or other anti-inflammatories with this? We can talk separately as well. But yes, ideally the mechanism should be the same. Look, at the end of the day, vaccine has spikes. Virus has a spike. That is a point of it. So their responses could be similar. The only thing is vaccine is not supposed to increase in number like the virus can and cause a destructive problem. But who knows, there may be the cytokines that are produced. If these spikes are causing the similar type of cytokines, then maybe the symptoms are similar. Vishavjit Singh says, do you prescribe Maraviroc to long haulers? If yes, what dose and duration? No, I do not, but Dr. Yo has been prescribing. This is part of their protocol. So just tweet at him, Dr. Yugandhra, and he can talk about it. Dr. Griffbean says, Dr. B, have you ever looked into the furin protein that has been ID'd on the spike of COVID that shouldn't be there? No other coronavirus has one. I have not. That is a, is this, so I'll have to look at it. Furin protein on the spike of the SARS-CoV-2. Okay. I would check that out. So Elk says that Sinopharm is attenuated. So going back to the question, if it is attenuated virus, then it is very different from AstraZeneca. I remember I talked about it. Attenuated virus means that we have a vaccine which has the actual SARS-CoV-2 virus, and then the RNA of the SARS-CoV-2 has been damaged, so it cannot replicate. And then that is the virus, original SARS-CoV-2. Imagine the dead body of the SARS-CoV-2 is injected into our system. And so our system it learns to work with it. I actually think that attenuated viruses are a decent vaccine. It produces more response to various parts of the virus compared to just the spike protein. The problem only is what I do not like about SARS-CoV-2 attenuated is how do we guarantee that all viruses are appropriately damaged and they are not active? So Ali G says, after AstraZeneca second dose, 7 days are enough to gain maximum protection, or it has to be 14 days? So a very good question and interesting answer. So originally 14 days. So 14 days must be. So 7 days is not enough. In addition to this, in UK's case, when they said, you know what, not even 1 month apart, the doses, let's take them 3 months apart. And they saw that, or at least they're saying, that the efficacy continues to rise for the first dose up to 3 months. And then you give the second dose and efficacy is uh, better. So I don't think it goes above the trial efficacy, but they say that this is the way better efficacy is produced from the first dose. So if you have the first dose and second dose, then 14 days after the second dose is the protection time. So Maureen says sun heat does not eliminate COVID, but can UV sun rays render it inactive? Yes. This is why those surfaces that are in sunlight and have gotten good sunlight for, let's say, 20, 30 minutes, they would have the virus inactivated. But let me draw something here. And that is, let's say this is a surface. And on that surface, if I can gross you out, somebody's snot is there. And so it depends upon how much is the infection or how much is the material there. And so sunlight may actually be able to hit this and kind of inactivate those viruses that are in the upper layers of this material, but there may still be viruses sitting in the deeper layer which sunlight is not reaching, or ultraviolets are not reaching that well maybe, and then they are not destroyed. So it also depends upon the material, the fomite making material, whatever is the substance there, the density and thickness of the substance, and if the sunlight can, UV light can reach all the way. Ideally, it should. UV lights are used for water cleaning as well, and ideally they penetrate. But the question is, in opaque systems like these, can they do it or not? I do not know. Taika H says, "Hi, Dr. Bean. My mom had her first shot, but now she had been exposed, not sure if positive. Her second shot is on May 19th. How long is it safe to wait to get second shot if not COVID positive?" So depends which is the vaccine. If I go with the UK's AstraZeneca, they kind of increase the duration between them to 3 months. So from trial point of view, there are set dates that they trialed with. So ideally, to get the same results as trial, the same dates should be met. But from UK's point of view, from their data, one can even wait for 3 months after the first dose, and the efficacy actually continues to build up. Kevin Brazda says, Dr. Bean, important question. Would you say that the predominant circulating COVID in the US is mostly B117, wild type specific strains? So I think it is mostly the Kent variant. So it is the B117. Now I think the 617, the variant that started from India, that might become more prevalent because it is becoming more prevalent in UK as well. Sorry. So yes, at this time, majority of the infections are by this new variant. Not new variant. It started somewhere in September, October in UK, and then about 6 months or more. Akash says, "Hi, Dr. Bean. Is it still necessary to take H1N1 vaccine after taking a COVID vaccine? Can't a COVID vaccine protect for both corona and swine flu as well?" So generally, no. The reason for that is that, so I mean, think about it. One coronavirus vaccine or protection is not able to give us enough protection from another coronavirus. For example, those humans who have, those of us who have human coronavirus, that is what I meant to say, human coronavirus, they are not fully protected from SARS-CoV-2. So now they are both same family, they are coronaviruses. So expecting a coronavirus uh, protection to be cross protecting other viruses is difficult. There is some cross protection, but not enough to say now the other things will not happen. Cheyenne has a question. What are antioxidants and what is their role? Very interesting question, Cheyenne. Kind of a little early time questions. So what happens is, let's say here is a cell. And when this cell is working, what it does is it uses oxygen, and it helps it, oxygen participates, it uses fuels. The fuels are, for example, glucose or proteins or other things, mostly glucose. It uses fuels and oxygen, and it makes ATP, or energy. So this ATP, or the little batteries in the cell, are the one that are used to help with all cell functions. Everything inside the cell works with ATPs. So you can actually see that every enzyme says, you want me to work, give me money. And that money is ATP, adenosine triphosphate. Now, to make ATP, we need oxygen's availability. What happens is there is an electron chain. I have done a video talking about CoQ10, and in that I have talked about electron chain. So there is an electron chain in here in the mitochondria, which uses oxygen to help make components which would then be used for ATP. So that is the role of the oxygen. Now the problem is that the oxygen, when it is being used, or when our cell is doing these energy generating things, it is kind of shuffling around electrons on oxygen and other things, not just oxygen, nitric oxide, hydrogen as well. So when those electrons are being shuffled, this oxygen can actually become charged temporarily. And that extra charge on it, which appears temporarily, makes this oxygen really, really angry and reactive. That is what we say, reactive oxygen species. What does that mean? It reacts with whatever is nearby. Imagine if you give a gun to a monkey and let it run around. So you could imagine that you would be very scared of that monkey which has a gun with it. That is what happens here, that this oxygen species has a gun with it, and that is charge. So wherever it goes and comes across, it destroys the membranes. Our cell is made up of membranes. So outside the cell is the cell membrane. Inside the cell there are many compartments which have a membrane around them as well. So wherever this little oxygen, charged oxygen, would attach, it would go and pull electrons from there or push electrons to there, and causing weird energy issues, causing the cell membrane. So if this is the phospholipids of a cell membrane, it can actually, these oxygen species can weld the phospholipids together. So imagine if you have a wall or a fence outside of your house and you weld it together, and now that fence is destroyed, it cannot do its function, it is just welded and it is broken. So reactive oxygen, we call them reactive because they react and they start breaking down things. In that process, they can eventually cause a cell to die as well. But sometimes they just break it down and cause some damage which need to be repaired. So these are the reactive oxygen species usually, and they're always made. We can't stop them from making because they're needed for energy related actions. We need to have antioxidants, for example, vitamin C, for example, other antioxidants as well, vitamin E, selenium, and so on. We need them to pick up extra oxygen species that are just running around, the monkeys with the guns, and just pick them up and say, okay, you know what, don't do this, or give me the gun back. So there are many such substances that are used. Vitamin C is one important one. So I hope that that answers that question. France says, I miss Chuck. So is Chuck Becker, does he not join us lately? Okay, so let's see. Serenity says, why are vaccines only helping long hauler symptoms for a few weeks? Anything a long hauler can do to prolong the improvement? So, what I do not know is, so this would be a long hauler where the vaccine is not helping actually. This may have a local immune response for some time, which made them feel better. There are folks, some long haulers, who receive the vaccine and it becomes permanently good for them. Otherwise, I have done this discussion before. A long hauler possibly has, imagine, a cell with the spike proteins in it, some monocytes. That is one possibility. Or an immune system cell that has become mutated, mutated in a way, I shouldn't say mutated, whose gene expression has become abnormal. It's not a mutation, it's a gene expression that has become abnormal. Or, and this one is still debatable, or the virus itself is still hanging out somewhere. Active virus. It looks like active virus does not hang out. Maybe the dead bodies of the virus is hanging out, or maybe the immune system is not working correctly, or maybe mast cells have become activated. And by the way, from mast cell, next week we'll have Dr. Tina Pierce from UK with us. She has been managing long haulers there. She has been researching long haulers as well. So we're going to talk with her about the mast cell activation syndrome and how she has been managing long haulers. So that would be an interesting discussion. So back here, because we have multiple possibilities, the question is, how are we trying to solve it? For example, if immune system is not working correctly, then maybe steroids would help more. Then, for example, if the viral spike proteins are sitting, then ivermectin may help. Or let's say vaccine may help. If it is a mast cell activation issue, then antihistamines will help. So as you can tell, and there may be more pathologies that we are not aware of. So as you can tell that if we give one kind of solution in a different kind of pathology, then it will not work. In general, whenever you'll take anti-inflammatory, you will feel better whatever is underlying. But when you'll stop that anti-inflammatory, the problem would appear again. So that means we have not fixed the underlying issue, and then the underlying issue needs to be figured out and fixed. So I think that is the basic answer. So if after doing some intervention, the symptoms have appeared again, that simply means that that intervention is not to the right target. Becky says, my brother-in-law may have COVID. When I looked at the IMAS Plus protocol, it only recommends 4,000 international units of vitamin D, which seems low. How much vitamin D would you take if you had early COVID? I would take 10 to 20,000 international units. And that's what I've been doing as well. Kevin Brazda says, Dr. Bean, what is the black fungus problem with COVID patients in India? So it is an opportunistic fungus that is appearing in patients who are diabetics and have COVID, or they have been treated with steroids. This is a general problem with steroid treatment, that opportunistic infection, including fungal infections, they start setting in. So I'm going to do some research to see exactly what are the cohorts of patients that are doing it. But I'm very certain that diabetics and folks who are on steroids will be getting it, or immunosuppressed. Oachita says, Oachita canine German shepherds and dog training. Okay. So while taking ivermectin, can you train Luffy? He's not a dog, but he behaves like a dog. So while taking ivermectin to prevent COVID, there is exposure to COVID-19 are antibodies and T-cell immunity created that is similar to a vaccine. Okay. So while taking ivermectin to prevent COVID, if there is exposure to COVID-19 and antibodies and T-cell immunity is built, is that going to be similar to vaccine? So this is an answer that can get my channel closed, but I'll give you the answer. And the answer is yes. So let's generalize this. Generalization is that if somebody gets the infection and recovers, then they have the antibodies or T cells, whichever part of the immune system helped them, they have it. And now, if the infection appears again, their immune system, if in the same state, will be able to help it again. The ivermectin's benefit can be, in some cases, 74% of the people that I have read. Dr. Syed Haider said 99% of the people. So I think various doctors have various experiences. Giving ivermectin's benefit is that if the disease occurs, hopefully the severity would stay less if it occurs. And that would allow the immune system to develop antibodies and the person not ending up in the hospital, and that would provide the immunity. So that is a way to look at it. The question still is, and that is the same question for vaccines as well. A vaccine is not 100%. That means a person who is vaccinated can become sick with COVID, can become even severe with COVID. Now we are seeing, and maybe even die too. So far, vaccines have been protective against death. So vaccine's role is to help produce the antibodies. Infection's role is to help produce antibodies too. So if I reshuffle your question and remove the ivermectin from here and say, if a person gets infected and gets antibodies, are they sufficient? Yes, they are sufficient. Akash says, what does interleukin 6 does in COVID? As generally said, it can actually disturb the body thermostat and keep a mild fever on the long time. So the interleukin 6 has multiple functions. One of the function is to reset the thermostat, to kind of put it to a higher level, and our body then tries to bring the temperature up, and that is fever. That is usually, fever is good to kill the pathogens. Interleukin 6 also is very useful to work with the other immune system cells to activate them. This is why we try to give interleukin 6 inhibitors during COVID, so that the immune system can kind of relax and become less active. So tocilizumab or Actemra is a drug that is used to modulate interleukin 6. Interleukin 6 would then help reduce the activity of immune system. Kevin Brazda says, Dr. Bean, are you familiar with the claim that the messenger RNA vaccine can cause a more severe response to COVID variants in patients? Is this substantive claim? So, Kevin, explain a little more. So, here, the thing that I'm not clear on, COVID vaccine, messenger, Moderna, Pfizer, they can cause more severe response to COVID variants in patients. So, somebody who already has COVID and then they get the variant, or are you saying that, let's say I have gotten the vaccine, Moderna. Now, if I get COVID variant, will that be more dangerous to me? If that is the question, please tell me, and then I can answer it according to the question. So L. Cunningham says, I've been taking ivermectin, caring for my mom, tested negative. Excellent. Liza says, cats get a coronavirus vaccine. Why nobody thought that? Humans who live so close to cats never thought of a vaccine for humans. Cats get a coronavirus vaccine. Yeah. So Rima says, any data linking J&J and heart attacks within a few days? Not yet. I have not seen that data. I've seen with the Pfizer myocarditis, but I haven't seen J&J being causative towards the heart attacks. So Rima, I'll have to do some more research. Did you read it somewhere or did you hear it? If you read it, can you share that document and I can check that up? Yes, yes, Doug. So the same authors of the study then after that study came out and the people became very, very nervous, and there were news everywhere that Israeli study says that even in the fully protected Pfizer patients, the um, variants are able to infect them. So then the author tweeted, and I had shown that tweet. Author tweeted that just to be on the same page, there are 6 points. And so she went over 6 points. And the point number 6 was that we did observe, so I'm going to draw it. They said, so this is, let's say, dose 1, this is dose 2, this is 7 days after the dose 2, which is supposed to be the full protection according to the trial and the company's claim. So between 7 days to 14 days, meaning 7 days interval. After 14 days, they say we didn't see any more infections. But during this little window of time, they saw some variants that were infecting the patients who were supposed to be fully vaccinated. My response to that was, fine, extend it to 14 days. Say that the full protection is in 14 days. Instead of that, that became a huge news cycle. Every news media was talking about it. So Dr. Drbeen says, long day at hospital, I'm ducking out. Have a good day. Rest, relax. Okay, so so Rima says 36 hours post-vaccination. So Rima, I'll have to do a person who we know died. I'll have to do some more research on that. So Kevin says, meaning that when you are vaccinated and you get the variant, then the response can be more intense. No. So that is not possible. It is so funny that there are rumors both way. One person started this incorrect science that after vaccination, the innate arm gets depleted, and that would cause no immunity when the actual infection attacks, and the person is now just in trouble. That was wrong, and that is wrong. This is another one. This is actually generated from ADE, antibody dependent enhancements, where they're saying that if you have the vaccine and the vaccine has created antibodies, and now the actual virus comes in, a variant comes in that the vaccine cannot really bind very well with. They call it leaky vaccines. And now the variant is just going to be attacking the body because body thinks I'm responding to it and it is producing antibodies, but the virus is not affected by that and it is just attacking the cells. What they miss in saying this is that our immune system is not a human being who looks at, I am attacking here and then I have done my job and I'm just going to sit down. Our immune system would find new antigens. So this new variant, let's say we were supposed to attack its spike protein and we are not able to attack the spike protein. So the variant is now running around free. What would it do? It would infect our cells. When the cells are infected, cells are not going to care that we already have a vaccine antibody made and we should now not break down this virus. Cells are going to get the pieces of the viruses. They are going to present them on their surfaces. And now immune system is not going to say that, hey, dude, I already made an antibody for you. Why are you showing me new antigens? Immune system doesn't know it is. Imagine that this virus is so different. The previous infection, previous antibodies cannot work against this. Then for our immune system, it is a new thing. So immune system is going to say, fine, here is a new antigen you're giving me. This is just like if somebody got streptococcus and then they get staphylococcus. Immune system is not going to say, I made something for streptococcus. Now why are you here for staphylococcus? Same way, here there is a virus that is so different. So either we take back our basic principle that the virus is not very different. If it is not very different, then it would be attacked by the immune system. If it is very different and it has escaped the antibodies that were already produced, our immune system is not going to say, I produce only one time the antibodies for this kind of a thing. This thing has changed its shape. I'm not going to make you more antibodies now. No, The virus would be picked up, it would be presented, our immune system would take it as a new virus and would attack it, and it would get ready, T helper 2 pathway, T helper 1 pathway, 5 to 17 days, and the body would respond with new antibodies and would work with it. Now, can this virus kill? Yes, because the original virus can kill as well. Is that a failure of the immune system? Yes, in the first case, in the original case, that was a failure as well. It is just acting as a very new entity for us. So, saying that somehow getting vaccinated actually would result in a more severe state is not right. Then the ADE part of the mechanism is that they say, you know what would happen is, here is the cell and here is the antibody, and the virus arrives in, and we have the antibodies present, and then the virus binds with the antibody. Antibodies function is to coat the pathogens. So virus arrives in, then the antibodies are present, and now this antibody can sit on the surface of a macrophage. Macrophages can bind with the constant part of the antibody, and then they can phagocytose it. And now there is a new route for the virus to get into the cell and possibly infect the cell. The problem is it's a hypothetical scenario. Our cells actually coat, our immune system actually does this, that let's say this is an antigen, something that is a piece of a bacteria or something. Our immune system coats them with antibodies and with complements. This is like sprinkling, sugar on a burger or something. Not a burger, some sandwich, something where we can sprinkle sugar. So let's say we sprinkle those, and then the macrophages come around and they look at this and they say, oh, yummy, I love to eat antibodies and I love to eat complement. And they would actually bind with them and eat this pathogen. This is a normal process that happens in our body. This is the way our body clears out these pathogens. So now saying, well, this would go in and cause ADE is just not right. So, Kevin, these are not actually possibilities from a science point of view. So Art Patron Forever says second wave infections that target more younger people exhibit sort of ADE hypersensitivity effect, something like the second shot of a vaccine, naive immune system not overreact to first exposure. I don't know if it is a correct science, Art Patron. Jody says, question, did you hear about India starting an ivermectin program? Yes. So in Goa, number one, they're generally now saying use ivermectin, but Goa has started it. And did you hear that WHO came out and said, don't do it. It can be, the safety is not known. So WHO, safety for ivermectin is not known. Liza says, I read that in some people, Brazil, India, T-cell are not responding fast enough. Explain, please. I heard a Brazilian doctor also saying that. So the concept of something not responding fast enough is the following. Let's say here is a cell and here is a pathogen. Pathogen arrived in the cell. The cell is going to present that pathogen on pieces of the pathogen on the surface, right? And we know that naive T cell will come into play and they would work with this, and they would either go T helper 2 or they'll go T helper 1 pathway, and then B cell will become plasma cell, or T cell will become or T cell would be activated, cytotoxic T lymphocyte will be activated. We know this mechanism. This part here can take anyways from 5 days to 17 days, even 29 days in some people. Now, if the pathogen is so aggressive that in this 5 days time, it is just causing so much destruction that the person dies. So then the adaptive arm did not respond fast enough. That is the general idea of waiting for adaptive arm, and during that time damage occurring. Sometimes it does not even work correctly enough. So the folks who are experiencing cytokine storm, Their immune system is active, but it is not working correctly. Now, saying this, that in some people, just this pathway is compromised and will not work fast enough unless they have an immune disorder. A healthy person cannot just say, you know what, today my CTL are not working, or tomorrow my plasma cells will not work. The how would the CTLs work, or the plasma cell, or what percentages, that is orchestrated from here, from the naive T cell and the helper cells. But they would work. The question is, they are different, their timings are different in general for different people. So you could say that somebody's T cells and B cells did not work fast enough, or the adaptive arm did not kick in. So let's say there is a person whose adaptive arm would kick in on 10th day. And then meanwhile, the virus is destroying their body and they're not able to fully handle it. Then you can say, didn't work fast enough. So Rajiv says, is it safe to get COVID vaccination for less than 1 year old baby? So Rajiv, that's what we discussed today a little bit before this discussion. Pfizer has just started a trial for 6 months and older. So we'll know about that soon. So far, it is not known. From previous vaccines, it is fine. Babies are given vaccines. But this vaccine has not been trialed and tested. So can't say about this one. Okay, so Musi says, ivermectin, any insight available into how it affects the gut microbiome? No, so that's an interesting question. We know that it works with the within the gut with the worms, but exact effect on the microbiota is not known to me. I'll have to research. Daniel AO says, what type of immune response is more involved in the cytokine storm? Innate immunity, which is non-specific, or specific adaptive immunity? So that's an interesting question. What happened? So short answer, it is the macrophages, possibly on the innate arm side, that are becoming mad. Now, are they becoming mad because the adaptive arm is not responding correctly? Or are they becoming mad because the adaptive arm is over responding? Is not known. We know that there are cytokines from the whole immune system, this part and adaptive part, both, that is seen. We know that the damage is being orchestrated by the macrophages as well. The question that is it macrophages that are overreacting because adaptive arm is not helping them, or is it the overreaction of the adaptive arm and production of the antibodies and then the resultant cytokines and the destruction because of that? We don't know. In theory, both arms, they amplify each other. So when innate arm becomes active, it amplifies the adaptive arm. First, it activates it, then it amplifies it by cytokines, and then adaptive arm releases cytokines that amplifies the innate arm. So they both kind of wind each other up to kind of keep becoming higher. In this process, there are regulatory cells as well that are started, which will work in a few days, and they would then try to calm down the whole system. And sometimes regulatory cells fail. That would mean both innate and adaptive arm are going mad, and the adaptive arms part of regulatory system is not working correctly. So exactly what happens is not known, because if we knew exactly what is happening, we would start controlling it. And you can see that after a year, we are still not able to control it very well. Rima says, does viral load have anything to do with which arm activates first? No. So that is the interesting thing. Different pathogens somehow provide different kind of activation on the macrophages and the dendritic cells. So let's say this is a macrophage, and let's say this is a dendritic cell. These cells have various pattern recognizers on them. And what stimulation of the which pattern recognizer plus what cytokines are produced would define at some point to say, are we going to go this route or this route? But we are not really very much sure how this route is selected. And so once again, I think that there are many studies that show that in a patient of COVID, if we know that we go T helper 1 pathway, they have less symptoms compared to T helper 2 pathway where people have more symptoms. So probably something to do with here with the cytokine storm. But we still are not able to tell our immune system that, hey, when COVID arrives, you should always go this route. We don't know how this happens. This is a thing that the immune system does based on various triggers, and various pathogens trigger various things. SARS-CoV-2 is interesting that in some people it is triggering T helper 2 and in some it is triggering T helper 1, but that separation between the two type of people is very dominant, meaning there are other pathogens as well that can incorrectly go to a different route and cause a different kind of disease, but these are rarities. SARS-CoV-2 has a very common go this way or that way pathway. Or to those who are listening, who are medicos, I totally understand that it's not that go this way or that way 100%, predominant. So let's say 80% to T helper 2 and 10% to T helper 1 versus, let's say, 50% here and 50% here and so on. So it's a percentage difference. So Rima, good question. Dr. Mobeen is being showered with questions from 500 plus people. I hope my son gets him as his professor one day. He's amazing, even while fasting. Thank you very much. The basic intent has been to be able to serve at this hard time. So I think that is what is helping drive this. So question, does having wild measles, rubella, and chickenpox plus a TB jab give you some immunity to COVID? As I know, some researchers are looking into the MMR jab and the TB jab as an option to protect. So good question. With the BCG, we know that there was some protection that was thought to be there. Australia conducted a very large study with the healthcare professionals to say, would that help? I haven't seen the results, but I think it didn't help. Otherwise, they would have come out and said this is protective. Now, the only way these vaccines could help is by cross protection. Cross protection is this, and so far we have not seen any of those doing it, but at least let me explain what possibilities of cross protection are. In the innate arm and in the adaptive arm, the idea of cross protection is different. So innate arm, cross protection means, let's say here is a macrophage, and this macrophage got exposed to, I'm going to make up something, let's say rhinovirus, a most common cold virus, rhinovirus. And what happened was certain genes in this macrophage opened up to make the response elements to that virus. And then this macrophage, or the lineage of this macrophage, continue to become exposed to this rhinovirus, and they now have those genes continuously open. Just like we are seeing with SARS-CoV-2 long haulers, some genes are just continuously open. And now this macrophage has learned to work with this respiratory virus. Now imagine if SARS-CoV-2 comes in, then it is possible that this macrophage is already ready. It already has the genes open. It already has the cytokines ready, and it is just ready to attack. So another virus came in and it just became active. This is called cross training, or not cross training. This is called trained immunity. This is called trained immunity. And innate arm can do this and can provide some protection. This is why we think children have lesser effect of SARS-CoV-2, because they're generally exposed to more respiratory issues, and their innate arm in the respiratory system is much more active and vigilant and has learned to work continuously. So it just very quickly becomes active and helps. In adults, we get less respiratory infections and our responses are less as well. On the adaptive side, we develop memory cells. So here, let's say we have two pathogens. Let's make any one of them. Let's say TB pathogen and COVID, SARS-CoV-2. Again, they have nothing in common, but I'm just going to make up something here. So let's say this is a TB pathogen, and this is the surface of the TB pathogen, and it has this little pattern on it, right? So these all pathogens have patterns. We call them epitopes. Those epitopes are recognized by the immune system, and then the immune system would make antibodies or cytotoxic cells against them. So let's say this is a pattern on TB. I'm making a wild example here just to provide an clue, not that this is the correct outcome. TB bacteria and this virus have nothing in common. And so let's say here is the SARS-CoV-2. And let's say on SARS-CoV-2 surface as well, somewhere a similar pattern is present. And that is another epitope. And this epitope, they both are similar. That means when our immune system learns to handle one of them, it may have cross-reactivity to the other one. So that is a possibility, and that is your question is about as well, that have we found any cross-reacting epitopes? And so far we have not. So that was a good question. M. Gregory, very good question. Is COVID more of a viral disease or inflammatory disease? So of course, in the beginning, it is a viral disease, but this virus is kind of triggering inflammatory pathways in a way that it looks like inflammatory system on its own just keeps going and does not stop. That is what is a cytokine storm, resulting in patient dying even. So when the patient is dying from COVID, at that time, it is not a viral disease. At that time, it is actually immune system dysregulation disease. So in majority of the people, it will be viral disease and will be handled as a viral disease and done. In some people, it would convert into inflammatory disease, and then there is a problem. Good question, M. Gregory. Roman says, Dr. Bean, please see my super chat. Many thanks. Okay, let's see. Let me catch it before it disappears. Or has it disappeared? Roman, it disappeared. My apologies. Can you please write it down again? So my software here shows a set number of comments, and my apologies, I didn't catch it in time. So meanwhile, I'll speak about William Goff's question. Any update on the patient you had that was double vaccinated, got ivermectin, and still ended up in the hospital? So till this morning, my morning, their night, patient was still in the same state, not deteriorating, and they had tested her by half an hour of removal of the CPAP, and she was able to maintain 90 with the nasal cannula. Now, consider this. I know that you're a healthcare professional. Consider this, that she had actually gone down to 80 and below. And from there, now she is maintaining on nasal cannula 90. So I think that is a good sign, but I have not gotten the response from them today. The reason for that is that it's the same problem. The doctors in the hospitals do not want to give things. So what happened was, my friend said to the doctor, it's a private hospital. So the pulmonologist there and the doctors there, my friend said that, hey, my friend Mubin from the US has sent me these things to do. And they said to him they said, has US not seen what they did to their own people? They have gotten world's most cases, and they've gotten the most deaths, and they are telling us what to do. The result was that they had a little quarrel, and he wanted them to use the prescriptions that I was giving. They were not ready, but they were doing it, and then they were not doing the tests correctly. For example, for oxygen saturation, instead of taking the arterial blood gases, they took the venous blood, and did saturation on that, which was really low. And so he said, I looked at that. He himself is a doctor. His wife is a doctor. He said, I looked at the saturation and I thought, she's about to die now. And so when he went there, then they said, well, we incorrectly took venous saturation, venous blood. So he said, why did you put it in the lab? So it has become a mess. So he became very sensitive to not offending them too much. And I was chatting with him that means for a patient, either let the patient die so that they are not offended, or end up offending them and they still would not give the drug. It is the same thing as Dr. Corey is fighting here with the court to say, give this patient ivermectin, and the hospital is saying no, and then he's to go to court and hospital is just dragging their foot on every step of it. It is similar to that. So he was quite disappointed last night because he was not able to get the labs anymore. He was not able to get the situation anymore. He was not able to say. So I had asked him to change the doses for some of the things, and he was not able to talk with them about it because they were saying, who the hell is Mubin and why would he tell us what to do? We know what we are doing. So that is the situation there. So kind of sad. And I am praying that she is okay and she continues. In my opinion, she's improving. But looks like, for example, I had said shift her to methylprednisolone, and they said no, we'll keep her on Dexa because Dexa is what is approved. I had asked for some dosage changes. I had asked for ascorbic acid, and they just don't want to work with it. Roman says, thanks for your gift of wisdom and knowledge to humanity. Please devote a show to explain breakthrough cases. CDC published an article from nursing home healthcare worker, real life observed. So I will do it. Let me take the, actually France was talking about this today as well. So okay, so we'll talk about that. Let's see. So there is a question. Lbug89 says, is India using ivermectin? Why are so many dying? So I'm going to invite a guest who will be here and who has been studying India's usage of ivermectin with data. And so hopefully we'll have some responses to this question with data. But what I know, now this is what is the anecdotal from my friends who are talking from there. And even when they are sending me messages, there are varying messages. Some are saying that, hey, we are using ivermectin. A person actually sent me a note saying we are using ivermectin like water. And then there are folks who are saying, my doctor doesn't even know ivermectin, or our healthcare authorities are not even working with ivermectin. But what I know so far is Uttar Pradesh was using ivermectin. They had very low number of cases. Even FLCCC were talking about their cases and how they were low. Maharashtra was not using ivermectin. Then Maharashtra, in this latest case, also developed more cases. Those cases went to Uttar Pradesh as well. Uttar Pradesh started getting immigrated infections as well. With this, now there are places that are using ivermectin, and those places have lesser load compared to those who are not using ivermectin. In addition to this, the Kumbh Mela and the Holi and the election campaigns, and I think people just in general getting stuck at home for a long time, there is a behavioral difference as well that arrived. This whole thing became a perfect storm. So now, considering such a large population, I don't think that they all have ivermectin or they're all using ivermectin. And not all doctors know it. I know doctors there who are part of my team who know how much I talk about ivermectin that don't use ivermectin. So I think this is a mixed bag. We need to look at the data more closely to have a clarity. So I'm going to invite a guest who has been looking at that data, who has been tweeting about it as well, and we're going to hear from him. So good question. DC says, does vaccine shed? What a simple and what a loaded question. So does vaccine shed? So there are so many interpretations of this question. And I know that there are in in the groups where people do not like to have vaccines, they have been saying that, hey, those who had vaccines and now they're shedding and they're going to make us sick. So let's see what are the possibilities of the shedding. So first of all, a person who is vaccinated, one interpretation of this open question the question could become that will they be receiving the virus and shed it, or will they not shed it? And I would answer this in two ways. First one, from FDA, they say we don't have enough data to say that. From vaccine companies, for example, Pfizer, they say that, hey, we have seen in Israel, and we think shedding is reduced by 76% or to 76%. They think it is reduced. That is vaccine companies. Now, my response to this is this. Let's say this person is fully vaccinated. That means when they will get the infection, it would take 24 to 48 hours for their immune system to get up, wake up, and respond. The memory cells to become active and respond. During that time, the variants are fast enough and aggressive enough that they start infecting the cells and they start replicating in them, especially in this area as well, where they actually enter the mouth, the throat area. My apologies, this is my human at this time. And then they would shed from there as well. So could they be shedding for a couple of days? Now, caveat, normally what happens is that if somebody becomes sick here, gets exposed here on day 0 or day 1, let's call it, it takes them up to 5 days to develop symptoms. The virus has to keep replicating, increasing in number, cause enough damage that 5 days later the symptoms appear. And the shedding happens 2 days before that. So this was the wild type, original Wuhan version. In the newer types, they're infecting faster. So instead of, let's say, symptoms to appear within 5 days, the symptoms might appear 2 days. I'm seeing people who are exposed to another person who had the infection, and the next day they are sick as well. If this is the case, then the virus load is increasing very fast in this person who is vaccinated, but still is infected now with a COVID, with the SARS-CoV-2 that is a variant and is able to replicate fast within this window of time where the immune system is still sleeping, and the virus says, oh, you know what, I can continue to replicate. Will this person shed? Yes, they would shed. Will they shed as another person who is sick? No, because the other person is going to be sick, coughing around, and then giving it to others. So this is the answer to, will a person who is vaccinated shed the coronaviruses? Now, if the question becomes slightly different, and the question becomes, will a person who is vaccinated shed the spike proteins, which I heard from some folks as well, and that was just that was a possibility. They said, here is another person, they are vaccinated, and because they are vaccinated, I do not even know how to write vax. So they're vaccinated, and because they're vaccinated, they have spike proteins in them. And there are folks who have generated this really weird thought in people's head that so when this pandemic is over, we humans should remember how medical professionals created mud. So let's say this is a cell. There are some people, I can actually name them. There are some people who started this set of incorrect science, that when the vaccine is given, that vaccine would cause the cells to display spike proteins on their surfaces forever. Meaning our cell would essentially become a coronavirus. And it is displaying the vaccine, the spike protein forever. Now, if you ask the question that will this person now shed the spike proteins? then the whole science is wrong. So how could I build on it to say, well, maybe the spike proteins will break off of the cells and come in the saliva. From there, they'll be shed. Maybe there would be cells that are shed and the spike proteins are on them and they're shedding. The problem that this is a wrong science is our immune system is not going to allow such a mutation to occur wholesale in our cells, that now cells are showing spike protein. This person's further conjecture was, or for her, this was the real science. The further message was that now when the actual virus would arrive in the person's body, actual SARS-CoV would come in and say, ta-da, I'm here, then the immune system would attack the whole body and spikes are everywhere, so immune system would just kill the person. And her point was that in a few months, you would see, this is what was said in January, that in a few months, people would just start dying. So that didn't happen. She said 2 months. Here is why this did not happen. It did not happen because imagine you become an immune cell. You are an immune cell. You are looking down here and you are seeing a spike protein. You know this is not a protein of ourself. It is a foreign antigen. If you are an immune system cell who thinks this spike protein is a bad thing, you are going to attack this spike protein and the cell and you're going to kill it, the cell. Example of such a cell that would do this job, natural killer cells. Example of such a cell, neutrophils. Example of such a cell, macrophages, dendritic cells. Although macrophages and dendritic cells would do killing after they become active. But anyways, these are all the cells that can do this. So now if we say this cell, immune system cell, is actually looking at this spike protein and is not responding to it, because that is her conjecture. Her conjecture is our cells would develop spike proteins on them and our we would just be mutated organisms. Then in future, when the actual infection occurs, then the attack would happen. Immune system would just say, wake up and say, let me attack this thing. The problem is, and check this out, immune system is not attacking right now. The whole body is showing spike proteins and immune system is saying, I don't care. I'm not bothered. This is called anergy, A-N-E-R-G-Y. Anergy is a mechanism where immune system accepts some antigen and says, I'm not going to react to it anymore. I'm fine with it. For example, people who are allergic, to them, allergists or immunologists give them small doses of the things that they're allergic to, tiny small doses, to develop energy over years and years. Now imagine if the energy has developed. Then tell me if the actual, so you are this immune cell. So my apologies, please be an immune cell for a second. Now the actual virus arrives and it also has the same spike proteins. If you are not attacking here, will you attack here? You will not. Why? Because you're energetic here. You're saying, I don't care. If you're saying, I don't care here, then you're going to say, I don't care here as well. So you're not going to react to the virus. You're just going to say, oh, well, that is what happens to human coronaviruses that live with us. We don't respond to them all the time. We're not fighting with them. Why? Because our immune system says, oh, well, you're here. Thank you. Don't kill us. We would not kill you. So let's take it the other way. We say, you know what? Immune system will attack here. That means then immune system will attack here as well. That means as soon as we become the modified organism, every cell of ours becomes genetically mutated, that moment we will die. Because the immune system is just going to attack it. So you can't have it both ways. And I'm not talking about you, I'm talking about the person who, you can't have it both ways, that it would attack on one side but not attack on the other side. Then the other side would come in and attack there. That's just silly. So now would this person shed? This whole thing is an incorrect science. So there is no question of shedding. Let's go to the third rumor of shedding. That is this rumor. Here is a person fully vaccinated and they have gotten the vaccine in them. Somehow their cells are manufacturing vaccine spikes and releasing them in blood like a factory. This is like a hormone cells, for example, thyroid cell making thyroid hormone. You know that there are specialized cells whose job is to do this secretion function. Every cell cannot just sit down and say, I'm going to make spike proteins and just throw them out. That is not possible. The immune cells would, in the near vicinity, they would see that this cell has spike proteins, they would kill it. If the spike proteins come out, macrophages, dendritic cells, they would pick it up, neutrophils will pick it up and clear it out. The spike protein normally from a macrophage or dendritic cell cannot come out, it would have to be presented on the surface. So now if you say, can this person shed spike proteins from its mouth? No. There's no concept of that. Now you can say, what I'm going to do is I'm going to take his cells. In those cells are spike proteins, and these are just some cells, not the whole body. Vaccine is not going to go change. So you're going to say, I'm going to dig into his intramuscular deltoid muscle, and I'm going to pull out those cells that have spike, and then I would want them to shed. That would not happen, right? I'm just making up a crazy statement here. So will a person shed like this? No. Now, there are more variations of this, but I don't want to waste your time. Generally, it is not possible. So I hope that that answers your question, and thank you very much for patiently hearing. Did Roman put that question again? Roman, I owe you an answer. Where is the... I'm going to try to see if I can find Roman's question, and we'll make that a last question. Skyfrog is Dr. Bean is getting a Luffy minded. So I wanted to make sure this shedding thing is discussed. Okay, so Roman, I'm sorry, I'm still not able to see it because it spent some time on this one. So let's do this. I'm going to see. Okay, so Roman said you already answered. It's about breakthrough. All right, good. So with this, let's stop for today. Thank you very much for listening in, for chiming in as well. Please like, subscribe, and share. And there are 3 links in the description. If you would like to support this work, you can buy me a coffee or become a patron or just support this work through PayPal as well. Thank you very much, and I would see you tomorrow morning. Bye-bye for now.